So welcome to the two-part webinar series, Implants 101, A Technician's Approach for Success. It is being presented by Jeff Carlson, CDT. Today is part 2, Restorative Considerations, and we are going to begin the webinar shortly. And with that, it is my pleasure to welcome back our very own Jeff Carlson, CDT. He is a senior implant specialist here at National Dentex. He has extensive experience in both the dental laboratory setting as well as working with dental implant manufacturers in the areas of education and technical and sales support. He has lectured both nationally and internationally on dental implants. Jeff is the primary author of a 300-page fully illustrated cookbook for restorative doctors and is a co-author of a corresponding restorative manual for auxiliaries that has been distributed in 8 countries. Jeff has also developed a 2-day training program helping clinicians improve their presentation skills, which has been attended by more than 200 dentists from 16 countries. And with that, it is my pleasure to say, take it away, Jeff.
Why, thank you, Jessica. It's just like you've done this before, once or twice. So, well, welcome everyone, and thank you very much for taking time this evening to hear some information on the what I think is a very needed area to talk about. And tonight is part 2 of Implants 101. Part 1 that we did about a month ago was really focused on crown and bridge. Tonight, our real focus is on overdentures and about options and considerations. We are going to have a little review on some key points and a few slides of that. I do need to do my little housekeeping, and just to say that I am a full-time employee of NDX, and I am being compensated through my salary to be here this evening. So thank you, NDX. And what I'm excited about is I've been fortunate to be involved in implants for about 30 years. I've been a technician for over 40 years. Hard to say that sometimes. And the information I'm going to share with you, there's some information that I've gathered over the years. Some of its newer concepts I've incorporated as well. Most of it is by personal experience, but there is quite a bit of the information that I'm sharing with you that is supported by literature, and I tried to add that references as we go along. So when I first started doing this book, this is 1996. That's actually me. So give you a reference of, I brushed the dust off of me here. Okay, so I thought it might be beneficial to hit some key points that we covered in part 1 for some of those of you that did not make it. So I'm not going to spend too much time on it, but I felt it would be helpful. And the thing that we talked about and what we've learned over the years, I've been very fortunate to be around some of the top clinicians literally in the world and sat in on many of their presentations. And we're working with a team of people many years ago, trying to really, how do we simplify, streamline, and make it scalable, this whole implant process of not just the clinical technical aspects, but even some of the verbal skills, the communication skills that are required for the team to be communicating with your patients, as well as then communicating with the laboratory, your implant partners, etc. On this call, we have quite a few people. We have several hundred people on the call. We have a mixture of specialists, general dentists, technicians, assistants, and hygienists. So really appreciate you all taking the time. I promise there's going to be something for everyone on here. And so I wanted to start just to say that we really came up with as a very fundamental, this works very well as a minimum, a 4-step process. And we broke it down to 4 steps, patient expectations being number 1. And then number 2 would be restorative options, and 3 is basic biomechanics, and 4 is a team concept. So what we mean about patient expectations is you need to know, what do the patient, expect their restoration to feel like, function like, look like, and then cost, of course, is something that is important. And this may seem very fundamental and basic, but if you don't really know what their purpose is or what their goal or their objective for treatment is, it's kind of like going on a trip and you don't have a final destination. How do you know, 1, how to get there? Secondly, how do you know when you're there? So patient expectation is kind of like your destination on a journey. And so it is, again, very important that you understand what they expect and listen to it in their words. Because once you know that, then the expectation is going to dictate step two, which is your restorative options, especially when we start talking about this topic of removable implant restorations. There's a lot of variety here. And this is where patients don't really understand, whether it's, tissue supported versus bar supported, implant attachment retained, fixed, fixed removable. I mean, these are all our words, right? But the idea is that, they have expectations that their terminology might be different than our terminology. So I'm gonna kind of go through that with you as well. But restorative options is really, if they're saying that they want something that doesn't move, doesn't come out of their mouth, well, that's from their patient expectations. Then that would guide you to know that in restorative options, you're not going to have a 2-implant locator overdenture because they don't want anything that can come out of the mouth. And they also don't want any movement. And I think most of you realize that if you did just have 2 implants, whether ball abutments, commonly the locator attachments, locator abutments, that there is movement. There has to be. The loads have to be distributed in the edentulous areas and not have all that loads going onto just two implants. It's kind of like having a roundhouse bridge on 2 abutment teeth. It's not going to last very long. So again, patient expectations is where everything starts from. It's your destination. And then that's going to help us with the restorative options. Then once you've kind of zeroed in on what option you're going to fabricate, then you need to start looking at how are you going to design this case, the biomechanics of it. So, I always say, I'll ask people in a group, how long do patients expect their restorations to last? Just, regular dentistry. And usually in unison, the group says a lifetime. And then I say, well, how long do you expect patients to think their implant restorations to last? And they kind of pause for a moment. Yeah, a lifetime. And I like to say a lifetime in 2 days, because they have very high expectations because, often insurance isn't covering any of it. It's significant. Some of these treatment options are very significant in cost. So the higher the cost, the higher the expectation. So it is very important that we were able to design these for long-term success. So now we have patient expectations, which led us to restorative options, which has led us now to biomechanics. And now the next step of the 4-step process is a team concept. How are you going to share that information? If you, as a restorative clinician, have been speaking with your patient, you've made your documentation and your notes and presentation to the patient, feeling pretty comfortable about the treatment modality and the plan that you're going to follow. How do you share that with if you're not going to be placing the implants, with our implant specialist friends, with your laboratory, and even with your team members? Another really important team member really is your implant representative. Today's major implant companies, they have some very solid, and even some of the smaller companies have some very solid reps that are a huge benefit to the practice, to your team members. They have a lot of knowledge, and that can be a real benefit. So don't forget about utilizing them to help be part of your team. So when we look at the considerations, these are some of the topics, this list here, that I would suggest that you kind of have like your pilot checklist of things to think about. You're getting ready to go on this trip. It's kind of like, what are you packing? Are you going somewhere cold? You need warm clothes. So, this is just kind of like your checklist, and we're going to kind of hit on each of these components this evening. So if you recall, those of you that were on our first webinar, Implants 101 Part 1, we talked about terminology and being able to communicate with each other. And Dr. Carl Misch created a really great classification many years ago. And this is one of my favorite books, the Dental Implant Prosthetics. It is an older book, but the information is still very valid today. It's not the only one, but it is a very good one. And the references used often, whether it's in literature, you hear clinicians speaking about it. What we covered was crown and bridge. And so a classification to identify the type of restoration He came up with this FP1. FP would stand for fixed prosthesis, and then FP2, and there's FP3. So we covered this last time. FP1 is a restoration that you're just replacing the clinical crown, and the FP2 is where there's been more bone loss, periodontal disease, where you're needing to not only to replace the clinical crown, but a portion of the root. And then FP3 is when you're getting into have to also replace the some of the tissue structures, and which would actually be some of the bony structures as well. So just as a visual quick recap here, on the left, top and bottom is your FP1. Looking at the bone, a lot of it has to do with bone resorption. And so FP2, there's going to be more bone resorption. And it just means that you're going to have that longer restorative prosthesis. We're going to talk about the classifications for removable coming up. The other thing about implant options, again, this is Implants 101. I understand some of this will be very basic, but some of you need this information. And a lot of times no one's talking at this, really a ground level information. So what I'd like to do is start with saying that as far as implant options, you have what's called tissue level implants. These are implants are where the actual one piece of the implant as a solid object obviously has an internal connection componentry to it, but it will actually be above the gum line or at the gum line at tissue level. So you can see here by this diagram, bone is coming up. Many of these implants will have roughened surfaces, the smooth titanium surface, and there's different heights of these as well. But those are referred to as tissue level. The most common implants that we're using, especially when we're dealing with the crown and bridge, and even dealing with what we're going to be covering a lot of tonight, the overdenture type of restorations, they're going to be the bone level implants. So just to clarify for some people that there's a tissue level implant and there's also bone level implants. The other thing that we talked about, and we're just going to have a couple more slides about our recap, is that it is when you're working with bone level implants and you're in the aesthetic zone, and aesthetic zone is not necessarily just canine to canine. For some patients, it might be first molar to first molar. It just depends on their smile and how specific and particular they are about their aesthetics. So one of the things we found is when you're placing implants, just the act of creating the osteotomy, there'll be some remodeling at the crest of the ridge where the osteotomy was created. Your body does not allow the bone to remain sharp edges. It will always round it off. And so there'll be some automatic remodeling regardless of the implant system. So it's important, I think, to keep your implants 1 to 1.5 millimeters subcrestal. So when that bone does do a little remodeling, you don't have any metal showing. So just a food for thought there. Then about when you're treatment planning and thinking about looking at available bone, it's not only, what is the bone quality this patient has, but it's the available bone. How much of that bone do we have available? Bone needs to be evaluated and measured 3-dimensionally by height, width, and as well as length. So implants range in lengths from, commonly 6-7 millimeters upwards to that 15-16 millimeters. The most common length implant we see are around 12 millimeters. Usually if someone is restoring a single tooth, if you can get a 12 millimeter implant in there, somewhere between 10 and 12, you feel pretty good. And then you want like a regular, what we refer to as a regular diameter implant. I'll touch on that coming up here. When it comes to talking about diameters of implants, this can be sometimes a little more confusing. Because one of the things you have the diameter of the implant, the body of the implant. You also have the diameter of the platform of the implant, or the top of the implant, or the restorative or prosthetic connection of the implant. Some of you have heard of platform switching. If you look, this implant on the left does have a little bit of it. You may not be able to see it real well, but kind of the schematic drawing here that I have my cursor on. Platform switching means when the prosthetic component engages into the implant, there's still a ledge of the implant out here. It's going to be beveled typically like this, and that will be the widest. This starts becoming some of the wider portion of the implant. So platform diameters are really They can vary by the implant manufacturers, but they often, today now we're seeing that you can get implants that have the same platform connection and have a variety of implant diameters, the body of the implant. The other thing I wanted to point out here on the right now, as you see, as far as the body of the implant itself, there's really two diameters that you want to take into consideration. There's what's referred to as the major diameter, which is the thread width, this blue line. And then there's the minor diameter, which is if you remove the threads, that cylindrical, or whether it's a tapered cylinder or even a straight, but you remove the threads, that's referred to as the minor diameter. Now, why is that important? When you're doing cases that we're looking to do undersizing implants, so we're doing these immediate load type of cases, be it crown and bridge or the full arch immediate load, or even if we're doing, simple locators when we want to be able to load immediately. But if you're in soft bone and you're undersizing the osteotomy, that it's important to know that you have to look at, there's going to be the drill, that the minor diameter here, that is a solid object going into the bone. You may have to open up your implant osteotomy to at least this minor diameter to allow these threads to pass through and then engage. The threads then will act as a seating device, and will screw, obviously like a corkscrew, would screw the implant into the bone and kind of pull the rest of the implant through that. But it's just important to be aware that it's not just the thread diameters, but the minor diameter that you should take a look at and consider, as well as for those of you doing the CAD designing, that you're looking, sometimes we're putting implants in very thin bone. So it's important to be aware of both thread diameters and minor diameters as well. Then close to the last things I want to talk about on a recap is that when it comes to implant styles, if you will, we talked about bone level and tissue level. Well, they'll have what's referred to as two-stage implants. And what that means is that the implant and the prosthetic abutment are completely separate. So this scenario is a two-stage implant, and the margin, then you have more flexibility. The margin of the crown would be on the abutment, and this can be modified, be it by design on CAD/CAM, or if it's a pre-machined abutment, can be modified with a burr. Now, even though it's referred to as a two-stage implant, these implants can be done in a single-stage protocol, meaning that you place the implant, good stability, you place the abutment, be it a temporary abutment or a final abutment, and then place a temporary provisional crown. So you're doing a one-stage protocol using a two-stage implant, if that makes sense. The single-stage implants become a little more limited, possibly when you get into the aesthetic zone, because the difference here is on a single stage implant, the actual margin of your restoration, if you can see on the drawings here, is on the implant itself. So this outside bevel is where the prosthesis would finish off at. So the margin of your restoration is dictated by implant position. So very important to keep in mind doing these type of implants in the anterior. Today, most people are probably using these posteriorly. They're a nice, solid, strong implant. In the posterior, maybe where aesthetics aren't as critical. Then implant placement and loading protocols. Really, there's kind of three of them, if you will. There's the traditional two-stage, place the implant, cover screw on top of the implant, close the tissue suture over it. Basically, the patient leaves as there's, other than a couple of sutures, they don't see anything. Single stage or early loading protocol, as far as a placement, single stage placement, that's where you're going to have as a minimum a healing abutment or a contoured healing abutment that would be placed on the implant and then is sutured around this abutment. So the top of the abutment is actually exposed to the oral environment, so that the implant is getting stimulated through, not from occlusion necessarily, but through patient biting bolus of food. Maybe you have a temporary prosthesis over it, but it is being loaded. And then also what it does, it helps to define or develop the emergence profile, which is very advantageous when you are dealing in an aesthetic zone, doing these crown and bridge type of restorations. And then the other type of implant loading protocol or placement is immediate provisionalization, which is where you're going to actually put the abutment, most often a temporary abutment and a temporary crown on. And then if sutures are required, suture around the contours of a crown. This is probably the preferred way in the aesthetic zone. Just have to be careful about how you're going to load that, as far as occlusion. What kind of a stability do you have, any parafunction, keeping in mind that bone quality as well. How long is the implant? How wide is the implant? These are all things that you kind of always need a pulse checking before you say, hey, I'm going to do an immediate load case. As desirable as it could be, there are limitations to it. And, the thing we don't want to do is have implants fail, because usually when they fail, it can cause more trauma to the surrounding bone. And it may not be able to do something as simple as replace that implant with a wider implant. It may need bone grafting. And now you're talking to a patient about more time, delays, hard for you to charge them for those things. But anyways, things to think about. So that was kind of a recap, very quickly recap. But now we're going to really get into the idea of overdentures and talk about what are some of our options and considerations. And so going back to our classifications, what Dr. Mish had termed, and a lot of people do use this terminology, is RP stands for removable prosthesis. And so tonight we're going to be focusing on an RP4, which is an implant-supported prosthesis. And it really doesn't require the extension of the prosthesis, be it maxillary, the palate, if you will, going into the palate for strength or stability, or going over the retromolar pads, catching and capturing buccal vestibules, labial vestibule as well. RP5 is going to be, as you see here, more of your tissue-supported, freestanding ball abutments, locators, so forth. So we're going to cover a little bit of all of that. So now what we want to look at is the idea of, we have to talk about patient expectations with this. And again, the options, and then we're going to cover overdenture, tissue supported, bar supported, and converting an overdenture to a fixed hybrid, which is something that is available now. And I wanted to share that with you as well. If you would, please. How's that feel? You imagine wearing that in your mouth? Patients are amazing what they can tolerate and put up with. I heard someone say this many years ago. They said, patients expect a lot of their dentures, and it's not much more than an oral wig. So how good is your wig going to stay on in a windy weather? How good is your denture going to function? When you're actually trying to masticate foods, etc. So the idea is that there's not too many happy denture patients, really. There are some, but they're far and few between. And you think about it, there is $1 billion market in these products. So it's just kind of a given dentures aren't going to fit. Our digital dentures, a lot more clinicians are being more comfortable getting into removable. Maybe they didn't have that much experience in dental school. And, they're getting these removable dentures, or as a younger clinician, you're coming into a practice, buying into a practice, or buying a practice that's been around for 30, 40 years. And you have a lot of edentulous patients, partially edentulous patients. So the great thing, though, the good news is that you have the opportunity with implants to give these people such a much better quality of life. I had a friend of mine, I was at his lab a few years ago, and he had all these brochures, in the shipping area. And I said, what are you doing with that? He goes, oh, we pass these out with all of our new dentures. And I thought, oh my gosh, once again, imagine yourself being this denture patient. I mean, it's just almost like you're you just can't really feel good possibly about what's coming your way, especially if you had natural teeth and you're edentulated. So we're going to talk about how to improve people's lives. And this is a great treatment modality for you to offer your patients, to my technician friends, for you to share with other clinicians and help them, especially the younger ones or less experienced ones. Doesn't always have to be younger clinicians. There's still clinicians that don't do a lot of implants, be it restorative or surgery or the both. So the thing about when we're talking about removable now, we got to focus a little bit more on the patient expectations, as I kind of alluded to a little bit earlier, that, patients' perspectives, our perspectives, people's perspectives, it's not always, what you're looking at, it's what do you see? And so here's a picture. So how many of you looking at that? I'll give you just a second. How many are feeling you're looking at someone looking straight at you, and just half their face is covered up? Some of you see that. Others are looking at someone from a profile. And some of you didn't see, you saw one but not the other. So this is kind of, you can look at it both ways and you can see both usually. So it's back to what is the patient seeing when they're looking at their smile. They have something that's called visual tolerance. Visual tolerance is something that the patient has seen, or we as humans, we've seen for so long, we don't even notice it anymore. They don't notice their teeth look like the flat, bleached out, or maybe they're not bleached out, but just we used to say, to show my age again, a silver dollar setup, where everything was perfect, like a piano, set up perfectly. And you see patients that wear dentures, and they're wearing a denture, yet they would be on TV and smiling and talking, thinking that they look fine. That's visual tolerance. So it's important that if you see something that looks not quite natural or aesthetic to you, ask them about it. Point out to them. If you see something, have you ever noticed that this tooth is longer or shorter, or this tooth is rotated, or your gum lines are not the same? And it's not, it's not an insult to the patient. Something that I've learned, that my wife does a lot of lecturing. I've learned a lot from her over the years. Is that, ask the permission statement, and that means to a patient, I want to look and see, look at your oral environment, look at your overall health, look at what you have. And do I have your permission to say, if I see something, to kind of just tell you anything that I can see? And it's totally up to you. You have my permission to accept any treatment or decline any treatment, but just so that I want to share everything that I see with you. What patient is going to say, no, don't tell me that, doctor? But it's amazing how just doing that permission statement kind of helps you feel a little more comfortable to point different things out. But do that, point out to them. Again, visual tolerance, they may not recognize that. Sometimes they'll say, yeah, I got used to that. We hear people talk about the guarded smile. The guarded smile is when you're taking photos for the laboratory or for records, and you say smile big, and they smile and go, no, real big, and they're like on their tiptoes smiling. They've learned they're embarrassed about their smile, so they've learned what's called the guarded smile, how to smile without showing their teeth. So it's important to talk about that with the patient. Talk about, especially overdentures, about the movement. Is, no movement, a little bit of movement? Are you just looking to be able to, my lower denture doesn't fit. I just wish I could, my upper denture's fine, but I just wish I could eat corn on the cob, but my lower just doesn't allow me to do that. Then, that could be something that what the quality of life is, that they want to be able to, eat a larger variety of foods. Maybe for that patient, simple 2 implant, even converting their existing denture, maybe conventional denture to a 2 implant locator denture. And I'm going to show you how to do that in this evening. Something very importantly to talk to these patients about is if they're even aware about bone loss, and if there's a concern about it. Now, the word resorption, like we, as in the clinical world here, we would talk, in technical world, we talk about bone resorption. If you type in bone resorption, on the computer, it still underlines the word resorption. The computer doesn't even understand the word. So we need to be careful about the terminology that we use with patients so that they understand what's being said, and it's more or less in their dental ease, if you will. Words that they use use their words. If they say, I want something anchored in my mouth, when you talk about implants, you can say this will help to anchor it in your mouth. They can relate to that a little bit better. But let's talk a little bit more about, this patient expectations and their motivation for the treatment. We as humans, we're commonly buying things that we want, not necessarily what we need. And wants are often the quality of life issues. We want something because we feel better. I drove my daughter crazy when she was a teenager, when she would come up and say, "Hey, I need a new pair of jeans." And I said, "Okay, I know you need a new pair of jeans, but what kind do you want?" And because usually need to be some kind of designer jean, what have you. So she needed the jean, but the want was the designer jeans. So wants really are quality of life issues. And so you want to understand what the patient wants. Then also, by understanding their want, you can justify, then look for the needs. Yes, they need to have maybe 2 implants or 4 implants to meet what their want is. Their want is, I want to be able to eat and not have my denture come propelled out of my mouth. Okay, that's what they want. Well, maybe they need is 2 implants and retrofit their denture. But if their want is, I want something does not come out of my mouth, that I don't take it out, but the dentist can take it out, then their need would be for at least 4 implants, possibly more. So just keep in mind, wants are quality of life issues. You want to know what those are. And needs are what you can provide to them to meet the want. So tie a want and a need together, you'll have a higher acceptance from patients, because now they're buying their want, but they can justify with their needs as well. And don't forget, all your patients, that have had tooth loss, whether edentulated, partially edentulous, and to even have some of their own dentition, but they have restorations. Everyone has a story. Take time and ask them their story. And when you ask them, tell me your story. How did you arrive at this? Just, listen. We have 2 ears and 1 mouth for a reason. So let them tell their story, because you're going to learn a lot from them. And so I'm going to kind of circle back a little bit about, and I hear I'm using the word resorption, bone resorption, but I'm sharing this with you all. We all know about the different stages of bone resorption, and this has been well documented for years and years. Here's your mental foramen, and when teeth are extracted, we know we're going to lose bone, especially if we start wearing dentures. We don't know, is this mandible here in the bottom left, is that 8 years, 10 years, 12 years? We don't know. Not all patients are going to go to the extreme on the far right, where, this is hard for them to even wear a prosthesis, because their mental foramen, the mental nerve, is right there, the nerve bundle, and it's sensitive. So one thing you can say to a patient, that wherever they are in treatment here, that they're at the best place that they're going to be unless you're going to do some bone grafting and things like that. So the problem is, does the patient really understand the effects of bone loss? So as clinicians and technical people, we can understand what we're looking at here, the photos. We kind of know what that would look like facially or aesthetically to a patient, but this is what the patients understand. This is what they know. They don't necessarily know about the resorption models I showed you, but they know what it looks like in a mirror. They've seen it on other people. They don't want to be like that. So they need to understand that the roots of a tooth, they help to maintain bone. When you lose a tooth, the bone has less reason to be there and will melt away. Melting is not a bad word to use. They can relate to that. Implants have a nickname. Implants are also nicknamed as bone maintainers. So if you did nothing more for a patient than if you edentulated them and put in, say, 5, 6 implants, never restored them, their alveolar ridge would maintain that height, because the body doesn't recognize the implants as a foreign object. It thinks it's a root of a tooth and maintains bone there, as long as it's not overstimulated, periodontal disease, etc. So this is your challenge: is how do you share that with a patient? Photos are a great way to do that. This is something that, when you start thinking about what we're trying to do for these patients, it can be pretty significant. This is a long time. I've had this photo for many years. But no root, no bone, no face was a tagline. So when it comes to bone loss, a very dear friend of mine, Cynthia Bollinger, started an organization quite a few years ago. It's missingteeth.org is the website, the Institute of Dental Implant Awareness. And they did a survey of quite a few people. I mean, a lot of people who actually were given implants as an option and said, no, thank you, to that for whatever reason, cost, fear of the procedure, time, whatever it was. But when they went back to those patients that said, no, thank you, and explained the consequences of bone loss, and they understood that, what that does, you lose bone, you lose facial support. It has more of an aged look to it. 65% of them came back and said, okay, yes, let's do the treatment, just knowing what the effects of bone loss. So it is important that you take time and communicate that with them. A way to help you with that, these are some wonderful, very inexpensive models from our friends at Salvin Specialties. These are just some plastic models. You can't really see, but it's on a board held with some like a plastic little stand-up board. Rubber bands on them. You can take them off. Patient can touch them, hold them, feel them. It's three-dimensional. And you can say, well, here's where you are today. We're going to, when we remove your teeth, you will lose some of your bone, and we don't know when it'll happen, but bone does keep kind of melting away over years. And the treatment's gonna, we have more treatment options in here than we do down here. But radiographically, a lot of patients, I've been surprised over the years. I've been involved in removable prosthetics since the mid 80s, quite honestly, and with implants in the early 90s with removable. Patients can really, they understand looking at a radiograph, and then intraorally, that's kind of how this translates. So for less than, I don't want to say the number, the price, it's very inexpensive. Patients need, they like to touch things, look at things, and it gives them another level of understanding. So I would really recommend that you get those. So patient expectations, we've covered quite a bit of that. I hope, there's more in depth to it than that. There's the psychology of the patient. But again, listen to their story. You're going to learn a lot from them by doing that. So then let's look at the restorative options. So now we know what their expectations are. It's kind of like, well, how do we choose? Well, the expectations are going to help guide you. So we're talking about, here we're looking at this is an FP3 over here. This is your hybrid, the all-on X type of cases here. But we're going to really focus on this evening are going to be your RP4s, removable prosthetics 4, and then RP5, which is going to be, these are non-removable. I should say that these are not relying on the prosthesis to help engage out here on the borders of the patient's anatomy of the alveolar ridge as you would for an RP5. So there is a list from A to Q that was developed many years ago with a dear friend of mine. I'll bring him up here in a little bit. But in a snapshot, this is, we kind of thought about what are all the things we need to think about, like your pilot checklist once again. Now, of course, we're talking about overdenture, so splendid natural teeth, okay, that may not be a part of that. Or if you're doing, crown and bridge, maybe you're not worried about, what am I looking for here? Maybe it's AP spread because you're doing a unilateral bridge or something like that. But in essence, this is a good checklist for you. If you wanted to just take your phone and do a quick shot of that, a screenshot, because there's a lot there. But then with each one of those, there's information to seek out and to learn about. So always asked about number of implants. I'll get a case in the laboratory and the doctor would say, so Jeff, what do you think? My first question, I would drive my doctors crazy until they really learned how to interact with me, is I'm going to say, well, it depends. What does the patient expect? But people ask me a lot of times when we're looking at overdentures and we're talking about locators, because it is a really great option for many patients to meet their needs and financial needs and maybe their personal needs. at least for now. Maybe they can segue into something better in the future. But people will ask a lot of times, well, in a maxillary locator, what's minimum implants to get rid of the palate? Because that's really for, especially patients, if you edentulate a patient and they've never had their palate covered before, that's quite a shock for them. The sensation of hot and cold. We still have taste buds in the palatal area, so it does change a lot of things. And the point here, the summary, the answer to that, I should say, is a minimum of 4 implants to get rid of the palate in a maxillary denture. And I would really suggest then that palate be reinforced, the prosthesis be reinforced with some metal substructure based upon the opposing dentition, patient's musculature, things like that. It could be just to retrofit their existing denture. Add, maybe they had 2 implants, you add 2 more, retrofit, remove the palate. Maybe it's because their lower dentition has mobility, they have proprioception, they know about their biting forces, they can sense their biting forces. When we're looking to go to more of these hybrid, the all on X, typically 4 implants is the minimum. 6 implants is very common. Some will be 8 implants as well. We're going to hit on biomechanics as well this evening, but this is just kind of a snapshot. A lot of things I'm trying to give you are just some reference points to say, okay, well, I know this, I need at least 4, but what are some other conditions that I might need 6? And then fixed bridge work. Again, we have to get more into worry about and be concerned about cantilevers, AP spread, etc. So one thing that we've learned over the years is more is not always better when it comes to implants. And, this, you got to scratch your head sometimes. Yes, this photo, I got this radiograph quite a few years ago, but you know what? I have seen things not too unlike this in recent times. So it's really it's a shame that some dentistry that's still unfortunately being done. So let's keep going here. Let's talk about our attachment options. We're going to talk about these overdentures, and there's 2 classifications of attachments. One is what referred to as a resilient attachment, and the other is a rigid attachment. And a resilient attachment is going to, you're going to have that mobility, if you will, of the prosthesis. These resilient attachments, their real purpose is to retain the prosthesis in place during function, speech, mastication, etc. Not necessarily to and to distribute the loads from those maybe just 2 implants or maybe it's 3 implants, and it's to help to that movement allows for the edentulous areas to take that load. As hopefully you all are aware of this, with implant dentistry, one of the key things to do for long-term success beyond patients' home care, which is their responsibility, is how do you design these cases to distribute the loads generated during function in a greater area as possible and as quickly as possible. To the degree that you're able to do that, that's where you see the long-term success on these restorations. So understanding the different attachment mechanisms and their purpose is very important. Now, of course, your knowledgeable laboratories will be able to really guide you through this, doctors. So, just I would say if you're not already connected with someone, implant laboratory, I say implant laboratory, that really has a lot of experience with implants, they can really share a lot and help you along this road. Then rigid attachments are going to be something that doesn't allow for as much movement, hater bar clips, things like that, that are more for that, just the rigid, and it's going to be more implant. Loads are going to go to that implant and then transfer from the abutment to implant interface to the implant to bone interface, and then next chewing stroke, and again, distribution of forces. So talking about some of our options, I'm going to get into some key points with some of these then. We're going to look at, tonight, we're going to look at overdentures with locators. We're going to spend a fair amount of time on that. We're not really going to get into the FP3 tonight. We've already done some PowerPoints on that. We have that available on InSequence website at insequence.com. There is a section on education, and it's called Virtual Learning Academy, and there's PowerPoints there that you could go to and reference that. You'll get my email at the end as well. If you'd like more information, please feel free to email me. I can help guide you to some places. And then we're going to talk about the bar supported. But these are options for an edentulous arch. All these that we're showing here are definitely options. FP1 is going to be your fixed prosthesis, where it means all clinical crowns, like a roundhouse, if you will. So let's talk about the locator specifically and get into some real detail about some applications of all this. So it does provide, adequate retention, again, based upon the patient's expectations. There is going to be movement, and that could surprise someone. And so it's important that they're aware of that. I think models also with attachments on it are very helpful to have, so patient can see the different types of attachments. A quick warning for you about that: when you buy models, and you have, here's a denture example with 2 locators, and you're trying to get it on and off the model, they can have a lot of retention. And what happens though is that the retention is they're not able to try to grasp that peripheral border the way it fits in a model, and they're pulling it off. And also sometimes because it's a model, it's hard. It's not like in the mouth where the tissues have give. They're soft and pliable, if you will, that the patient gets this retention off that model. Wow, that's great. But then when they get it in the mouth, and maybe it snaps into position, but it has some movement because it's just on tissue, and tissue sometimes can be, again, it has that, it's flaccid, it has some movement. So I would suggest on your models to adjust inside the denture itself, so that the model, the retention the patient's feeling on a demo model is really the attachments, how much the attachments are holding. And we all know that there's different attachment inserts that have different retention levels, and we'll talk a little bit about that as well. A nice thing about locators that is the retrofitting existing dentures. For those of you that are just getting started maybe with implants, this is such a great thing to offer a patient to really help improve, step up their quality of life by giving them something that does not come propelled out of their mouth when they laugh, sneeze, eat, and to even being intimate as well. Some drawbacks, and is that you still, like I mentioned, you're going to have the mobility, and you still have to do a reline. And a reline doesn't necessarily mean, I think you all are aware of this, reline doesn't mean that it's the prosthesis, the integular side of the prosthesis wearing. Relines are done because the bone is resorbed. And so keep in mind that the patient's still going to need that. And a lot of them think, oh, I got my implants, I never need to come here again and see you. So, relining the implant, the prosthesis after, it just kind of depends patient by patient, but just be aware that, it'll definitely need to be relined. The attachments will need to be replaced. It's kind of like tires on your car, wipers on your car. They're very important if they are going to wear. This is something that I wanted to kind of get a little bit more into, is understanding about inner arch space. And then we're going to talk about implant positions. So we talked a bit about, bone quality, and it's not just the bone quality, but the available bone. How much bone do we have? And again, some quick numbers. I'm going to just give you some quick numbers here. A height of at least 10 millimeters of host bone or the patient's own bone, and a ridge width of 5 to 6 millimeters. If a patient has that as an alveolar ridge that's 10 by 5 by 6, typically there's some good things we can do for that patient, very predictable things we can do. When we get into the restorative space, about that restorative space really typically it's referred to or measured from the platform of the implant, the top of the implant, to the occlusal plane. That also very often would be from the alveolar ridge to the occlusal plane. And different types of restorations require different amounts of inner arch space for enough material for strength. A locator, could be as short as 5 to 6 millimeters, but it kind of depends on where those locators are. If there's going to be a denture tooth over that as well, then maybe, you might need a little more room because, if it's an upper or if it's a lower and they have a smile that actually shows they're lower incisors, you need to just be aware that you're going to have room for the abutment, the housing that goes onto the abutment, the cap, if you will, the attachment itself, and then acrylic within the prosthesis for strength, which is going to be about 2 millimeters itself. And then when you get into your different types of all-on-X cases, a titanium bar with acrylic denture teeth, it's going to be somewhere around 15 millimeters. You can get with a hybrid, a zirconia full contour, an all-on-X type of case, maybe about 11 millimeters. Now, some manufacturers and implant manufacturers have, and some laboratories can do some different things to bring that even less. So I think that what I really want to say here is that be aware that there's room that's needed. There's room that's going to be required from the top of the implant to the occlusal plane. Many of these patients you're working with have a closed or collapsed vertical. And so you may need to be open their vertical up, one, from a function and aesthetic perspective, but you also might be able to do that to allow to have enough room for some of these restorations. And then, patient selection, again, it gets going to get into about finances. What can they afford to do? How about their home care? Can they, if it's a bar overdenture, do they have visual, are they able to see? Are they arthritic? Can they go in and get a dental, a super floss underneath these little frames and in between teeth, et cetera? But, determining what the prosthesis you're going to make for that patient, as you see, there's a lot of things. It's their own expectation, how they're going to maintain it. What kind of bone do they have? How much bone do they have? The room that you're going to have, et cetera. So there's also been some classifications, just looking at this, where if we don't change the plane of occlusion here, this blue line, but when you have bone resorption, that's crown to implant or crown, it's already caught me. It's crown to root ratio, but in our world, it's crown to implant ratio. And, that ideally should be a 1-to-1. If it's a 10 millimeter implant, the crown ratio should be much more than 10 millimeters. However, that all depends too on how wide was the implant, musculature, bone quality, posing dentition, things like that. So one of the reasons that the locator is such a popular selection for these overdenture cases is its low profile compared to some of the other options out there. It can be almost require about half as much of inner arch space. Some things I want to share with you too. Now, whether it's locator, ball abutments, but these freestanding abutments, that there's a cuff height or a collar height to these abutments. And what you need to be aware of is that patients, there's, we need room, as we're talking about here, there's room for the inner arch, the patient's vertical. You need to evaluate their functional vertical dimension of occlusion, which that's what most of us, I imagine, is called. We have our natural dentition, or we have we're not into dentures, and we have a pretty well-established VDO. But when you put your teeth together, that is when you swallow and your teeth are together, that's your functional vertical dimension of occlusion. Now, when you just are sitting up straight, and if you're relaxing and you wet your lips and just relax, many of you might just be sitting there, looking at your screen. If you don't have your arm under your chin, if you're like this and you're relaxed, your teeth are not together. If you just close your teeth, that's where you are in a rest position is called your physiological rest position. The difference between physiological rest position and your functional vertical dimension of occlusion. If you close now, relax, that's your freeway space. That's freeway space. Typically, you want to have a freeway space when you're doing these removable prosthesis to have around a 3 millimeter of freeway space. If not, the patient's teeth are going to be bumping during speech, and they're just not, it's going to drive them crazy. So we're not going to get into establishing vertical that much tonight. Tonight was more of a broad, I mean, that's something we could do, get more in depth with some other courses, being really specific on different topics, maybe just do 1 hour long meetings on those. So here's that 5 to 6 millimeter space that we were showing a bit earlier, and does not include, that's above the gum line here, looking at that. But the other thing to keep in mind is that when you're selecting, so to my doctor friends out there, if you're going to, and you can bypass a laboratory if you're going to retrofit a patient's existing denture, maybe you place the implants, you refer them out to a specialist to do it. But when you're selecting the abutment height, the collar or cuff height are interchangeable terms. But you want to have select one that the collar, the height of it, not the height of the abutment, but the collar here is at least 1 to 2 millimeters above the highest point of tissue. If not, there's a high propensity of tissue invagination or tissue ingrowth over those areas, and it becomes more of a hygiene issue for the patient to try to maintain that tissue, and sometimes it could be cause some pain and discomfort to the patient. So you want to have select these abutments that are going to be more than 1.5 to 2 millimeters above. I mean, a doctor gave me this photo years ago, but I mean, here's a prime example that can happen. So it's not uncommon. So we want to be careful when you're selecting these cases that we're making the right measurements and getting the right measurements. When we're talking about a little bit about occlusion in forces and how it affects bone and implants, there's really three types of forces that are generated. Compressive forces are the ones that are kind of pushing objects together. Tensile, we're looking at, they're pulling apart. And then shearing forces, as it says here, is disrupt the interface. That's more of your fracturing. Those of you back in our day, you're doing PFMs, you fracture off a buccal cusp, still can happen today, but that's a shearing force that causes that. And this is just an interesting point. I think that cortical bone is strongest under compressive forces, and it's actually weakest under shearing forces. So when we're setting up our occlusion, this probably had more to do in crown and bridge cases with more fixed, stable restorations. And for our FP3s, our all-on-X type of cases, when we're working with overdentures, be it locators, ball overdentures, hater clips, Dolder bars, things like that, that could be a little bit different then, because we'll touch base a bit on that coming up here. So I did want to pay homage to, we have people in our world that's really made a difference for all of us, and one is Dr. Charles English. Unfortunately, we lost him way too early, but he was the one that worked with me in developing that ADQ checklist. We were together for a couple of days when I was working on the book many years ago. And, he was gracious enough to just I had him think out loud. What are the things you're looking at cases? What do you look for? And that really got us into, and he was the person also, I'll give him credit for coming up with the anterior posterior spread, AP spread. That was by Dr. Charles English, I think it was in 1988, or it might be 86, the critical dimension, when he first brought this to all of us. And basically this is still very valid today. And the way this works is, so let's say that we have an arch, and we are going to look at the question is, how far can we cantilever past our posterior terminal implants? And what he looked at I think he told me over 1,400 cases. He looked at cases that succeeded and cases that failed. He looked at what the comparisons were, and he found synergy and similarities on the ones that were holding out at 5 years to 8 years. And he found that if you could take and draw a line through the center of the two anterior implants and draw a line, and this could be for your proposed implants, or if it's an existing case, lab techs. So if you're getting a case from a doctor and they're wanting the cantilever back, this is how you want to help to determine how far back you should go. Do you have two bis and 2 molars, or is it 2 bis and 1 molar on a quadrant, or maybe it's 1 bi and 2 molars? Something to think about. That could be more advantageous on a prosthesis to have 1 bi and 2 molars, because you have a better surface area, better chewing efficiency, and that actually could be less stress to the prosthesis and to the system being prosthesis, implant abutment interface, implant to bone interface. Because they're more efficient, they're not having to chew as much as maybe 2 bis and a molar. Got off sidetrack there, but I wanted to throw that out to you. What we're looking at here then is what Dr. English figured out. I call it the magic number, which is 1.5. So whatever that distance is, and implants are not always perfectly lined up, so you just kind of get, this is a guideline. This isn't engraved in stone, but it's a nice guideline for you. So here we measure between the center of the implant and center of the anterior implants, center posterior implants. This particular analogy scenario is 8 millimeters. So the magic number he found was that if you take 1.5 and you multiply the space by 1.5, that tells you the maximum that you should cantilever past that distal implant. Now, doesn't mean you automatically do that. You have to look at what's the opposing dentition, what's the musculature like, how wide is that implant, how long is that implant, what's the quality of bone, and again, I think I said parafunction already. So it's a guideline. It's not just a hard, fast rule. And also think about this too, that the cantilever isn't necessarily to the last tooth. The cantilever is anything that extends past the last implant that has the propensity of a bolus of food, i.e., let's say a raw carrot, they bite down, or something hard, and it catches the extension of the denture. That is a cantilever. So it's not just the tooth going back 12, my tooth distal, the occlusal table ends 12 millimeters from my terminal implant. Yet I have a 5 millimeter flange extending back here, maybe up under the retromolar pad, and that patient can bite down. That cantilever goes all the way back to that. So please keep that in mind as well. The other thing to keep in mind that Dr. English shared with me, which I didn't really think about, when he's looking at a model, I said, what are you looking at? He said, I always look at the curvature of the arch, because the curvature of the arch can, play in your favor as well. For an example, a tapered arch, typically you can probably find that you can get a greater AP spread as opposed to maybe an ovoid arch or a square arch. And, and quite frankly, when you have a scenario like this with a square arch, and say the implants were all placed between the mental foramen and the mental foramen, and, there really is no AP spread here. So, do you cantilever? I would say that I would be very cautious about doing that. Maybe nothing more than some type of an attachment that comes off the back of that. Or this would be a good one for a hater bar with a clip if you're doing a removable, or locators on a bar, something like that. But again, it's just to kind of show you, about arch form, and trying to give you some numbers and understand some limitations. This is kind of a snapshot. I would suggest again that, take your cell phone and take a snapshot of these bullet points, because when it comes to cantilevers, the idea is try to avoid them when possible, minimize them. And if you can, think about cantilevering. If you can, cantilever toward the anterior, not necessarily the posteriorly. People always think about posterior cantilevers. Well, maybe you can get an implant posteriorly, or 2 implants, and then cantilever anteriorly. Biting forces at the first molar are 4 times greater than biting out in the incisor area. So we can reduce the forces on that cantilever if it's something more to the anterior as opposed to posteriorly. Additional implants. Again, if you are needing a cantilever, maybe 4 implants is not going to be adequate. Maybe you should go to 5 implants or 6 implants. Keep in mind, patients are going to expect these restorations regardless of what they're paying for it, whether it's $5,000, $8,000 or $20,000 or $40,000, they're going to expect it to last a lifetime in 2 days. So, design these accordingly and to help do that, and also keep their expectations in check with what they are agreeing to or willing to pay for, because they may want to have the stability of a fixed all on X, but they're paying you for, a 2 implant overdenture. So again, keeping all that in check prior to surgery is very important. An explanation before procedure is an explanation after procedure is that's right, an excuse. So let's not get into that mode. That's not good for anyone. Okay, so let's think about this now. Let's talk about implant positions. So now you have a patient, whether you're going to edentulate the patient or they're already edentulous and they've just decided, I'm for whatever reason, I'm ready now. I want to get some implants. So again, back to what, Mish, one of his classifications, and I just really like a lot of the ideas and some of the concepts here, but divided between the mental frenum and the mental frenum into 5 equal sections and call them A, B, C, D, E. And from that, he came up with these classifications: overdenture 1, overdenture 2. But what the point really here is to think about, if you're going to start off with a patient, when I say position implants for an upgrade. So maybe the patient this time, for whatever reason, fear of the process, money, whatever it is, that they're only going to say, let's just do 2 implants. And I want to do, we'll do that overdenture. Well, that's great. But if you plan your implants in the right position, say you put those 2 implants either maybe in the A and E position, then maybe it's 3 years later, 5 years, it doesn't matter, whenever, they may say, you know what, that was nice, but I have some money now. Maybe I inherited some money, whatever, won the lottery. But now I wanted some more implants, and can I get that bar, or can I get something more fixed that's not removable? And so by planning where you put those implants, think about where could you put future implants. And so, because a lot of patients, I see it very often, they come back and the doctor says, okay, Jeff, well, give me a surgical guide. And it's like, wow, the ideal positions are kind of messed up here because of where they were placed initially. So again, things to think about. I wanted to share this with you too, because when we're talking about removable, it's a challenge to have, be it with implants, having stabilized occlusion, but even getting a patient's bite is very difficult. And a lot of people are doing what's referred to as a mush bite. You have occlusal rims, and maybe you go ahead and you're doing your VDO measurements, and you're finding your vertical dimension of occlusion, your functional vertical dimension, and they're closing down into bite wax or bite material. I was taught this by Dr. Frush back in the mid 80s, who was the founder of Swissident. Dr. Joseph Massad is one of his primary disciples, if you will, that has carried on his legacy of knowledge and has expanded from there. And hats off to him for all he's done for all of us. As a dental profession, Dr. Massad has been wonderful with a lot of that. This was something that was shared with me out of frustration when the doctor was talking about, we were talking about central ball bearing bike recorders and Gothic arc tracings. And I went, oh my gosh, that's fine. But a lot of people, that's just, people just doing mush bites. What can we do? Well, he's shared this with me. He said, Jeff, if you just take, this is actually from a tooth card of wax, could be utility wax. But if you take a pyramid of wax and you make about 5 to 6 millimeters, 7 millimeters tall, push that wax, push it onto the back of the occlusal rim, or if it's their denture, you're taking a bite at the median suture line. So you see the height of this little cone built up, and you tell the patient, you show them that, you say, okay, Mrs. Jones, you see this little bump of wax I have back here, and it's important you put it to the posterior extension of this base plate or their denture. And you say, I want you to put the tip of your tongue on that and keep your tip of your tongue on that. While I have you closed into we're taking your bite registration, if your tongue comes off, no problem, let me know and we'll just start over again. Because here's what happens. When you're taking these bites, a couple of things can happen. One is posture. if you have the you should be taking bite registrations with the patient sitting really upright, not laying back, especially with their head back, because right away the condyles are going to go in a retruded position. But sometimes people say, oh, I know that trick, Jeff. Put the tip of the tongue in your roof of your mouth. Well, here's something that Dr. Frush shared with me, was that when we go into functional closure, meaning there's something between the arches and we're closing into it, i.e., let's say some bite wax, let's say, and there's some resistance, the condyle not only sometimes can go a little bit up and down, but can do some shifting. And I remember, in the laboratory, we get bites that would be, the doctor gets a wax set up and says, everything looks great, but the bite, here's a new bite. It just did a wash bite on it. And that's a whole reset, re-wax up. It's like, hey, it looks great. Just adjust the bite and go to finish. So these little left and right shifts, I found that this eliminated about 25 to 30% of our lateral bites that were being missed. So hopefully this will help you as well. So what you do is you tell the patient, put the tip of their tongue on it. I would like you all to do this. You can do this because you're in the privacy of your own home or somewhere that no one's looking at you probably. Put the tip of your tongue at the junction of your hard and soft palate. Try to move your mandible left or right and don't move your tongue. It's almost physically impossible for you to move your mandible and the tongue not move, meaning that the patient keeps their tongue back on that wax. The tongue will act as a centering mechanism to help them go into more of a pure closing arc. So as you're watching, maybe you mark the nose, a dot on the nose, a dot on the chin, and you have a Bowley gauge or something, and you're having them close down a little more, and stop. It really helped to eliminate stopping left or right, but it was more of a pure bite. Because if you tell a patient, just put the tip of your tongue in the roof of your mouth, I mean, I can do that. My tongue stays in the same place and I can move my mandible everywhere. So hopefully you found that as a helpful tip. I've worked with that for many years and it's been worked pretty well. I'm not saying it replaces ball bearing bite recorders, Gothic arc tracings. It's just sometimes a down and dirty, easy way to try to get something better than just a mush bite. The other thing I wanted to share with you, for our technician friends, that looking at the shape of the alveolar ridge, the height of the alveolar ridge helps to determine what type of cusp fossa relationship. Do you have a 33-degree denture tooth, or is it a 15-degree? When you see a flatter the ridge, the flatter the occlusal should be. So the residual ridge anatomy really helps to give some guidance to the to what type of occlusal inner cusp to fossa relationship that you have. Something else that's a great little tool, because when we're doing these denture cases, the canter, anterior, posterior canter, and then the fiend of all is that left and right canter, going downhill, trying to make an occlusal rim. This little bite plane from Ivoclar is really slick. I don't remember the cost there. It's very, very minimal. It's just plastic. But what you can do is if you have an occlusal rim in the mouth, you just push this and hold it on that occlusal rim, and you can look and see how you're lining up with the Camper's line, which is from the alus of from the ale of the nose to the tragus of the ear, the Camper's line. The occlusal plane should be parallel with that. Here you see the photo from below that we're looking, pretty good with that. If it's not quite right, you can either adjust the rim until you get that, or take and put some tray adhesive on this little bite fork. Key the occlusal rim as well, like you were taking a bite registration. And use some blue mousse here and put that in, and you physically hold that bite plane until it's in a proper position. It's kind of acting like a pseudo face bow. But again, these are things, it's not to replace a face bow, but I know a lot of people are not using face bows. So this is something that can just help get the plane of occlusion, whether it's just for a visual reference point, but this, you got to have this. This is just a wonderful little, it's better than a, tongue depressor. It's too small. A lot of different ways people lay that out here, or the cotton tip and what have you. So hopefully we're doing okay so far. We're at 7:15 Central Time, and I still got more information to rock and roll through. So here we go. We're going to get specifically now on, with the locator componentry and doing a retrofitting an existing denture, and talk a little bit about doing new dentures. So let's dive right into it. I would also say, Zest, Anchor, really a good company, good friends of mine, are there, very helpful. They have a lot on their website too, PowerPoints that you can watch. So there's a lot of information there, and there's a lot of information on YouTube. A lot of people post. Dr. Michael Shearer is one of their key clinicians, doing a lot of education. Great person, great reference, very knowledgeable. So there's a lot of information out there beyond what I'm sharing with you today. Some of these fundamentals. Just know that they have different ranges available. Again, your lab technicians are going to take care of this for you. I really wanted to share with you those. We're seeing more and more clinicians, trying to provide their patients economical alternatives. So if you're going to select the abutments yourself and just retrofit an existing denture, that's really what I want to help you with in these next few slides here. So understand we're talking about the gingival height or the cuff height on locators. There's always going to be this given of a 1.5 millimeters from the top of the locator toward the implant. 1.5 is where the housing is going to kind of fit over that. The remaining portion becomes the cuff height or the gingival height. And that's the part I was referring to a little bit earlier, that you want to make sure that you have this. Now, these are not going to have as much of an issue of that tissue ingrowth as you would where you have a platform like a ball abutment. Those are the ones that are more notorious for those kind of issues. Locators, that's not going to be your issue unless you get too short of one, and then it's just going to be more of a hygiene problem for the patient. So hopefully you all know this tool has been around for quite a few years now. They used to have just that little hook one, but now there's a new one as well. And this is going to be a useful tool when it gets into their new locator, fixed locator that I'm going to share with you at the end of the presentation. Again, just be current, with this information. I mean, with the instrumentation. And I got to tell you, a lot of people don't even realize that on that tool, that little gold handle, there is a hex here, an 050 hex, that that one end fits over the abutment itself, so that it would engage inside this kind of like little trilobe area here. It would engage that area, and then the torque wrench, the hex tool, would fit down inside of here, and you could torque that abutment into place. So there's also, this is the tool itself. This is probably a more predictable way, only from the standpoint you can see it fit, engage a little bit better. If you get off a little bit, you don't want to strip those and strip a tip off, so that they have the latch type or for an insertion torque tip, but for torquing the abutments into place. Then there's also this little device here that shows you angulation. You can, so say as a restorative doctor, or as a laboratory, let's say, but I'm thinking if you referred a patient out to the specialist, they placed a couple of implants, and now you're wanting to, you're going to bypass the laboratory. Sorry, my technician friends. But you're going to, so you have healing abutments in place. You can take your hex driver, seat it into the healing abutment, use that shaft as your reference point. You take this little gauge and you just kind of line it up. And based on the angle, you can see this is straight up and down, but this helps you to see if this shaft was over here or way over here. It gives you a reference of the angulation that you may need to correct, because there are availability now with these with locators. There's some companies that do custom milling that you can get, angles, 40-degree, I think even more than that, custom abutments machined. So one more time, looking at this, what you want to do when you're measuring cuff height is get your probe to go down to the platform of the implant, and you want to measure at the highest point of tissue here, because aesthetics are not an issue here, but you want to get to the highest point, and then that's where you're going to kind of make the decision of what cuff height to utilize. So again, you want to get taller than that, but measure to the highest portion of the gingival height. So we're talking about retrofitting, this chair side. So if you're placing these abutments, It's just, again, here's an example. The implant's in the same position here on left and right images, but the cuff height is different. And so that's just going to bring you through the tissue a little bit more. So hopefully that's clear with you. Otherwise, if you don't get tall enough, you go to seat that, it's going to pinch the patient's tissue. So now let's say that you have received a case that had healing abutments in place. And now 2 healing abutments usually are not that hard to keep track of, but these abutments the clinicians can use different heights, different diameters of them. But if you get in a situation where you have multiple healing abutments, a little tip is take a piece of rope wax, shape it in an arch form. As you take them out of the mouth, have the assistant, put them in that little rope wax as the position they came out. It prevents you from having to doing a lot of eeny, meeny, miny, mo, which one goes where. And if they bump a tray, these don't all roll around on a tray, etc. So here we are. We're going to go ahead now. We're going to retrofit an existing denture. Now they're showing ball abutment here. This could be the top of your locator as well. I'm going to show you a couple ways of doing that. One, with those little indelible sticks, you can just, moist it with their saliva, little dot on there, take their denture, seat it. And then now you see those little reference points here. That's where those abutments are. Another nice, easy technique too is you can just I'll squirt some fast set material in here. You don't need tray adhesive. Fast set, close them down. You'll get an indent in there, and then you just drill right on through that area. Open that area up. What I'm showing here then is that you want to relieve the denture so that you can see that we've got not just the abutment itself, because we need to have room for the housing. So when you're going to relieve inside of a denture, and there's actually Zest has some nice tools as well that create some undercut in here to remove the right amount, and a burr goes in and creates undercut. So they've been doing this for years. They got some neat instrumentation to make this more predictable for you and more user friendly. What I wanted to show you here is when you make that recess in the denture, that you don't want to just look at the abutment itself, but the attachment mechanism, that when it seats on top of the componentry, that you want to have of your pickup material at least 1 to 2 millimeters of space, because you need to have that much thickness of this material, be it Zest chairside, maybe some Voco material. Quick Up is a nice one. Stellar Material is another good one. Stern Gold, Easy Pickup. These are some good materials, but for bonding, some do need bonding agents. But you want to have room in here for that material when you're bonding these attachments into the denture for strength. Otherwise, they're just going to fracture out in no time. So then now we're ready. We've relieved our area. We're going to take a little bit of Vaseline, put some Vaseline in the integular area, of course, not into where your attachment is to be bonded to. And then always use the little spacer rings that come with your abutments. I think just about everyone's going to have them. And the spacer rings are very important to utilize. So you'll snap that over the abutment that's engaged the implant, and then seat your attachment. Then this is a very important and easy thing to do. You want to create what I call a vent hole. And so what this is you're in a closed environment. You can't see it, meaning that area that you just created, the recessed area where we're going to bond that attachment in. You can't see it when this goes in the mouth because the denture is covering it. So what you do is, like I found the number 8 burr works the best, as you drill a hole so that the vent hole is going to be right at the top of the abutment. You don't want this vent hole at the bottom of the abutment. You want it at the top of the abutment, and I'll share that with you coming up here. So now we've got the spacer ring in place. We have the attachment seated onto the abutment. We're going to take some more material. 2/3 is going to be plenty of material here because, again, you have that housing that's going to take up space. Vaseline, this area makes it easier to clean up your flash. But what's really nice when you see here on the right is when you seat that, And it's nice to also take some cotton rolls, one on each side, and have the patient close down so there's even stability occlusion. And the excess, because of that vent hole, and also it's a nice idea to put a little Vaseline on the outside of your denture here in the lingual palatal area, so that nothing bonds to I call it a worm of material that expresses out. But that vent hole allows the air, any trapped air, to express out, and then the excess material. By getting the air out of it, it makes that material stronger around that attachment, versus having air bubbles in it. Obviously, that's just going to weaken it. So then you can either, while it's not set yet, you can take your finger and just wipe off that excess real quick, and then close the patient down with cotton rolls, and tell them, do not chew around, do not talk, don't, other than just swallowing, just hold still while that's setting. If you're using a material that's, I think dual cure material is probably your way to go, which again, the Zest chair side is dual cure. The lights today that you're using can penetrate pretty well through the acrylic. Still a good idea that you have dual cure. Look, don't rush this. One of the worst things that happens is you go in there and maybe you go, oh, I did 20 seconds with the light here and 20 seconds here. And you do the other ones and you take it out of the mouth, and it's just a little string of that material because it didn't cure all the way. Now you've got to start over again, clean that out. So, don't rush this part. Give it time. Let this dual cure portion do its process as well. Then when you remove it from the mouth, using a smaller tip here, you just backfill any little voids that often does occur. Maybe the spacer ring created a little bit of a, maybe an air trap. You want it to be kind of hygienic. And these spacers that you use, this black spacer here, these are processing inserts. So I believe that's actually what they're called, is a processing insert. And utilizing that tool, now that you've processed it, you want to use the processing ones when you're in the mouth doing that. You don't want the patient to leave with those in place. They are not given any give. They are very rigid to keep the denture in place. So their only purpose of these black processing rings are for processing it. So you take the tool and you insert it, pulls that out. Then the other end of this is the older tool, but the new tool functions fairly similar. You put the new insert on. I would also encourage you on a new one to try the least retentive at first. Pop those on. You'll find many times for that patient gives them plenty of retention. But if you go with the most retentive and they go, well, that's okay, what else do you got? Well, I don't have any more. Psychologically, if they go, well, can I get any more retention? You have about 4 different options here, 4 or 5 options of retention. But also, if you get too strong, the patient cannot get it out. And then there's going to be an issue for them to, as far as for home care, how they get it out to clean if they can't get it out. So just a thought about using a least retentive and see if that works for them. So that was retrofitting an existing denture. Now what I wanted to cover was, what are you going to do if you wanted to do it with a new denture? And from the new denture, you have 2 options. You can do an implant level with impression post on the implant, or what's called an abutment level. I found on YouTube, you just type in locator impressioning. There is so much posted on YouTube. Good news, bad news, right? There's a lot of information in there. So if you're fabricating with a new denture, and you want the lab to do the processing, the attachments in the denture, that's an option. So you remove the healing caps, insert the impression copings. You can do closed tray or open tray. This one is showing an open tray protocol for doing that. They do make these little, so a friend of mine, I just heard her lecture. She said, oh, they're upside down champagne glasses. I said, okay, that's fine if you want to call them that. But these are like for a closed tray type of an impression, but these will snap directly onto the locator abutment. So you've selected your locator cuff height, you've ordered them, they've come in, you remove the healing caps, you seat your locator abutments, you snap these on. This nice undercut in here is going to capture is going to get locked in the impression. And so then now you're going to take the, they're just kind of showing it again, take the impression. The laboratory, then they'll get your impression, then they'll drop in analogs that replicate the top of your locator, pour the model or scan the model, and do a digital denture or do the conventional denture. So now I'm going to jump into something that I'm pretty excited about, because it gives the option to help to take patients to the next level with their prosthesis. And it's not the panacea, but I think for the right patients, the right scenario, this can be a really good option for these patients. It's called the locator fixed. And what's nice about this is that the locator fixed, you can convert an existing like 2-implant locator, and it can be utilized in some different scenarios. But what I'm going to just kind of, what I really want to do here is make you aware of it, to go find out more about it. So it's not my intent to go in depth with you on how to do this, just to make you aware of this. But these locator, the attachment is a different type of attachment where the patient is not going to be able to remove the prosthesis. These can be utilized inside of pretty much all the different types of final restorations for an all-on X type of case. Whether you start with it new that way, or let's say you're going to just retrofit their existing denture. So this was something I got from their website, is that, so here's your locator removable on the top half here, and here's your locator fixed. So this all looks pretty much the same right here. Where it changes is, whoops, sorry, hit the wrong button, my bad. Here we go. The housing will be different. The inserts are going to be different. And so they're case specific, as it's referred to, but you can take the denture, once you've picked these up, you cut the borders off that denture, and you can backfill the concavity in the denture with acrylic, and literally do some type of a retrofitting. Might be a little bit much for you to do chairside, but just be aware of it. I would encourage you to look into it more and make a decision for yourself if it's the way that you would like to go with the case. This was, they also have multi-unit abutments that are available to help for angle correction on some of these cases. Because and the unique thing about this is this is the tool. The patient can't remove it, only you can remove it. And this is a tool that's utilized on how they're going to get that out, the way this the wire goes around and you pull on it and it pops the denture up, and go in between the implants to do that. So again, I just encourage you to look into it some more and make your own decisions. What I wanted to get into now was I wanted to talk about the prosthetic. I want to get into about a couple different little tips and pearls that I think will be helpful in the next 20 minutes or so that we have here. I think most people are aware that, there's different types of connections of implants. You may inherit the external hex implant. Some are still being used. We're seeing them being used again now as zygomatic implants. We're seeing the external hex coming back. Most of us are seeing probably some type of internal connection, be it, internal hex, internal lobes, as you see here, or, the Morse taper type of thing. Then impressions, we kind of covered this in Implants 101 part 1, but you have direct, when implants are divergent more than 15 degrees, you probably need that. Scan bodies, are available as well. But what I wanted to get into was this right here. Not too many people are talking about this, is that so this is for my doctor, our doctors, who you're placing abutments and you want to know, how do you know if your abutment is seated completely? And so, people think, I'm going to just, panels may not always work based on where the implants are. There's some distortion as you come around the curve of the arch, the corner of the arch, I should say, that it may not pick this up completely. But here's a tip for you. If you look at your radiograph, whether you're using a pano or a periapical, bite wing, etc., I like to say, Periapical, do a periapical, but think bite wing. When you can do a bite wing in certain areas, that's great to do that. But here's my point. If the threads are blurry, you cannot be certain if that abutment is completely seated. This happens to be completely seated because the threads are, you're perpendicular because the threads are there and you see no gap here. Well, as opposed to this. So here's an abutment that the doctor actually told me that I was chairside with the case and said, no, I'm seated, I look good. And I'm looking at the threads and it's all blurry. I said, I'm sorry, but you need to take another x-ray because we can't be certain. And they were reluctant to do it, but they did it. And I was kind of excited because I'm going, nanner, boo-boo. Here you go. There's our threads. And look at that. There was a gap. So I just think that whenever your connection's below visually, where you can see it below the gum line, that it's not a bad idea just to do this. You've got the digital, way of doing it now. So it's quick and easy to do. The other thing I wanted to say is to know what your implant system you're working with, how the components should look like radiographically. That may sound like a stupid thing, but I tell you, let me ask you this. Is this abutment seated? I mean, look at these. This is a beautiful radiograph position. Threads are great, but look at the gaps. We got it. Here's the end of the screw. There's a gap down here. There's a gap here. Is that seated? Well, in fact, for this particular manufacturer, it is seated. You're going to find that almost I believe this, I don't know, I've never seen one that it's not, there is always going to be space at the end of the screw to the where the end of the milling of the inside of the implant has been. There's always going to be a gap here. So there'll be a little bit more of a translucent look here. But here's your vertical stop. This implant is this coping is a non-engaging. And this coping then, so there's a gap here, but look at it. It's completely seated. It's vertical stop. It's there. So this one's correct. Now, here's an abutment of a company that has more of that internal locking taper. And now this abutment is making contact here and making contact here. Well, here's our gaps, but wait a minute, the gaps sometimes are already there and we see this, but is that abutment seated? Well, again, know your manufacturer, how it should look, because this is how this particular system should look, where it is sealed completely. There is no gap in these areas. And there's less space here at the apical of that screw. So again, when your radiographs are important to make sure things are seated, but getting the right radiograph is also important. So we're going to touch a little bit on the biomechanics, and I'm going to hit just some real high points on this. Again, I made this comment, our treatment planning is all about surgically and restoratively focusing on distribution of stress. To the degree we can do that, we're going to be much better off. So I want to talk about bone quality because this is very important that everyone's aware of this, not just the implanting surgeon, for tactile sense and determining drilling sequence, how many implants, etc. So this classification, type 1, also can be referred to as D1 or density 1. Dr. Mish, again, with Dr. Kent Judy back in I believe it was in I want to say it was the early 90s, had this classification. And what they shared with us and looking at and what has been accepted in implant dentistry for 30, 40 years, just about. So type 1 bone is typically, not always, is found in the anterior mandible between the mental foramen and the mental foramen. People also say this tactile feel, this is kind of like oak wood. It has a denser cortical bone, not very medullary, not a lot of vascularity. Type 2 bone is most often found in the posterior mandible. And then this would be referred to as something like spruce wood as far as a tactile feel. And then the premaxilla typically is often referred to as like balsa wood. And as you're seeing too, that the image, the cross section here is getting more trabecular, more spongy looking bone. And type 4 bone, the posterior maxillary, will be referred to as, type 4 bone, and often, like almost like styrofoam. But what's important to note here, that helps you to decide, bone quality to a patient means, when do I get my teeth and how much does it cost? And what I mean by that is, poor bone quality means you're probably going to need more implants for better stability, more implants, more cost. Length of time, you place implants that are in D1, D2 bone, and sometimes we'll see D2 bone or even D3 bone, maybe in the anterior mandible, but you want maybe that to go 5 months. This type 4 bone, maybe you go 5 months with that instead of 4 months, or instead of 3 months, or maybe you immediately load a type 1, type 2, multiple implants, cross arch stabilization. Maybe you load a type 3 and maybe even type 4 with 6 implants, cross arch stabilized, based upon opposing dentition, musculature, etc. So I'm hoping that's kind of coming home with you. So we want to know about bone quality, and then we also want to know about available bone. And keep in mind that bone needs to be evaluated three-dimensionally, the height, width, and length of the bone. And that's how we're going to get that third dimension of width is going to come from your CT scans. Angle of implant, be aware that when we're angling implants, that it can have an effect on compressive forces and shearing forces and the tension forces. This was from Dr. Paul Bynon, found that when research that he was doing, every 15 degrees, the load is off the long axis of the implant. About 25% of the load is translated right to the bone, to the abutment implant interface. So it doesn't mean you don't do that. Of course, we do it all the time, but it's something to be aware of when you're trying to decide how many implants. If you got, angled implants in here, poor bone quality, parafunction, opposing is an implant supported bridge. All those things have to take those into consideration. Or just kind of mention this, opposing dentition. That has a big role in, on your design of the case. Biomechanically, how many implants do you need? It's going to be different if you are opposing a supported implant prosthesis versus partials or dentures. Parafunction should always be evaluated. Look for the indicators. The patient has natural dentition. Look for the abfractions as an indicator of clenching. So, what are you going to do to help offset that or control that or minimize the effect of parafunction on your implant prosthesis that the patient's expecting to last a lifetime in 2 days? When it comes to occlusion, this is going to be very fundamental. Because it's a bit about understanding, from the patient's perspective, one, there's a lack of periodontal ligament, okay? So they don't have that proprioception. They don't have a sense of really sometimes how hard they're biting. If you think about it, you have, with your natural teeth, you can put a hair between the enamel of your teeth. You can feel a hair between your teeth. To me, that blows me away, to think that the enamel of the dentition, you can still have a proprioception, and the hair, they say, is an average hair is 75 to 100 microns. So, that's how important the periodontal ligament is in giving patient a proprioception or a sense of how hard am I chewing. So you got to keep in mind they're not going to have that. So when we are trying to axial load implants the best we can, premature contacts, this gets more difficult. This is probably more predictable to establish in your crown and bridge cases, your FP1, FP2, and your FP3 cases. For your overdentures, this could be a little more challenging because the occlusion is all on a lower, let's say, the lower arch occlusion is in a dynamic. It's moving. We open and close in a spiral dynamic movement. So it's not, we don't chew like a cow. We don't chew up and down and back and forth. We chew in that spiral dynamic movement. So, when we're looking at, your denture occlusion that you already have learned about, lingualized occlusion is probably the best way to go. The safest way to go is nice lingualized occlusion group function. In your overdentures, again, you want to try and design the anatomy, the occlusal anatomy, not too deep, yet you don't want to necessarily go with all flat planes either. So again, working with a good laboratory, your smart removable implant technicians will know how to help select the right denture teeth for your prosthesis. We did touch a bit on cantilevers, and I just wanted to say that, you know, cantilevers are a magnifier of force. Just remember that. They're a magnifier of force. So whenever you're going to incorporate a cantilever, kind of ask yourself about, okay, what's going to be as a result of this cantilever? You know, did you follow the guidelines of AP spread? Again, don't automatically go there if you don't need it. Keep in mind that if a patient gets to, in their prosthesis, first molar occlusion, they have 90% of chewing function or efficiency at first molar occlusion. So to gain another 10% by going to a second molar, and if you had a cantilever further now, you already cantilever, let's say that first molar, now you're going to cantilever to that second molar. Are you really setting this case up for long term, or are you setting up for propensity of a short term or fracture of the appliance? That's the other thing. Cantilevers are magnifiers of force. So it's not just magnifying the force, torquing, wanting to torque that implant in the bone, pulling on it, creating tension forces, but it's your prosthesis. And if it's a denture and it's acrylic, you could, you know, that's significant that you could be putting some forces and causing fractures with that. So, you know, there's the do's and don'ts. The don'ts kind of cantilevers weigh out the do's, but, you know, just try to use multiple implants. If you're going to have, if you see cantilevers, look for more implants to go that, again, you know, wider, longer if you can, and then cantilever toward the anterior if possible versus the posterior. We're getting really close to wrapping up the end, so we'll have a few minutes for questions. So again, this is one of those slides that you're welcome, you know, take a snapshot of that. It's a lot of information there, but, you know, really in cantilevers, I just say avoid when possible. And if you're going to do it, really evaluate the pros and cons of it. What can you do to minimize the impact that potentially could happen from that cantilever? You know, and just watch out when you have these smaller diameter implants, shorter diameter implants, opposing a fixed implant bridge. Patient doesn't have that proprioception. Biting forces are going to be pretty darn hard. So hopefully that's been of help to you. And, you know, if you think about pretty much other than showing you the chair side portion of this, retrofitting the locator, a lot of this has been about, you know, pre-surgical treatment planning or planning the case, identifying the proper patient. And so we've shared a lot of information. I went kind of fast. I hope that you were able to, you know, still glean some from this. They're going to have this up where you can, it's available for review again. But the next thing, you know, is this team concept, coming back to now sharing all three of that information, the patient expectations, the options, the biomechanics with the team. I found this out early on, that if you as a restorative doctor and you're referring this case, your patient to a specialist to have implants placed, or to you know, anyone who's doing just referring it out to a clinician placing implants for you. Write down the patient's expectations of their final treatment, because a couple of things. One, if you can't write it, you don't know it. And that's where you should pause right there and say, wait a minute, I don't even know what my destination I'm going on this trip. I don't know where I'm going. How am I going to know when I get there? So that's one thing about writing the patient's expectations and sending it to your clinician you're referring to. The other is it helps them, because you're referring to them because they're obviously are experienced in doing this, that they'll look at what the expectations, no movement, not coming out of my mouth. And maybe you didn't have enough experience to talk about 5 implants and that poor quality D4 bone. The clinician knows, the surgical clinician knows, I need to have this conversation with the patient because we're going to need to put more implants than maybe what they were anticipating. So the team concept, it's very important to share all this information, because there's, you know, the laboratory, again, working with solid, good laboratories, and there's a lot of them out there. They can really help you along with this and you know, and help guide you through this. And so again, share all that information, share study models. of the pre-existing, so that these young technicians like this, they can grow old and feel like they had a good career. And I just want to say thank you so much, everyone. And let's go ahead and see what we got for some questions, and I'll see what I can do to help things.
With that, we are going to close this session. Thank you, audience, for attending this
Yeah, thank you
evening.
so much, everyone. Really, really appreciate it.